Really very honored to be part of this excellent panel. I thank ACOM for convening us. Want to talk about racism and health broadly, but I was also asked to talk about racism and mental health. I am now at the American Psychological Association, but I've spent many years in public health and health equity circles. So while it's clear that racism has a powerful impact on health and mental health, I want to encourage us to really work upstream, as many of our speakers have alluded to address the structures and systems that create illness in the first place. So let me just review a few key points. Clearly, experiences of racism and discrimination are related to depression, anxiety, and many other mental health challenges. And of course, during this pandemic of COVID-19, many families are experiencing enhanced stress, but this is particularly true for families of color. In our most recent American Psychological Association Stress in America survey, we found that 55% of African Americans are reporting that discrimination is a significant source of stress for them, up from 42% just a few months ago, clearly related to some of the overt expressions of racism and intolerance related to the pandemic, as well as other economic and fears about contagion of the virus. Racism-related stresses are also associated with chronic disease, hypertension, heart disease, etc. Racism is a public health problem, as our speakers have said, so we need to be very clear about that. We also need to be clear about what racism is in order to tackle those challenges, which I'll get to a little bit later. Many of the determinants of health and mental health are the same. People need access to high quality, timely, culturally excellent care. We need to address geographic and financial barriers, which remain despite the Affordable Care Act and its highly uneven enforcement. We recently saw good news in that telehealth is now expanded to include mental health service providers, critically important as we see a coming mental health tsunami related to social isolation and economic anxieties during this time of pandemic. But we also need to be thinking and acting at structural and institutional levels. Some years ago, I was very honored to work at the Institute of Medicine. I served as study director for the report that was entitled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. Many of you are familiar with it. It really rocked healthcare providers, educational institutions, with the reality, the realization that overwhelmingly the research shows that people of color receive a lower quality of healthcare on average relative to white patients, even after we control for differences in insurance and income access-related factors. The IOM committee deliberated about what might cause these factors, and we found that disparities were due to things like uneven insurance. We all know that there are tiered levels of insurance coverage, higher quality versus lower quality coverage, people of color disproportionately clustered in those lower tiered plans, and that's if they're lucky enough to be insured. Still, people of color are disproportionately uninsured, limiting their access to care. Medical apartheid, the reality that healthcare remains separate and unequal is a factor that the IOM report also alluded to, but the evidence since Unequal Treatment's publication in 2002 has grown that these structural inequities abound, related to not only insurance status, but geography. Place matters. Overwhelmingly, the systems that serve people of color are under-resourced and face many challenges, particularly with the growing health care burdens imposed by the COVID pandemic. It's also true that biases are clearly a factor, both explicit and implicit biases. And when the IOM report concluded that implicit bias was part of what infected the clinical encounter, many health professions were indeed shocked by that conclusion. But clearly, bias and implicit bias, as we know now, plays a part in almost every human being's life. All of us harbor biases. Our challenge is to surface those biases to mitigate them. Clearly, implicit bias plays a role. We now have a large body of research showing that biases do in fact infect the clinical encounter based on race, based on gender, based on many other factors. But it's also true that these biases can be fomented or encouraged in certain systems, and I especially appreciate the conversation about situational biases earlier. These biases are more likely to happen in stressed systems, systems that have few resources to order testing, diagnostic testing for patients, time constraints, and the complexity, the cognitive complexity of patients' concerns. All of these kinds of conditions are more likely to bring about implicit biases on the part of providers who are trying to fill in missing information. I'm very proud that that IOM study resulted in a number of important changes, such as changes to curricula in health professions education institutions. But we need to do much more as health professions organizations to address those structural and institutional factors that are really at the root of racial and ethnic health inequities. Healthcare only accounts for about 10 to 20% of population health, as many of you know. We need to address the social, economic, and environmental factors which are at the root of these inequities. Dr. Ross Lee, I believe you are from Detroit, as I am. I was born there in 1963. When I was born there, I lived in an integrated neighborhood, which quickly became all Black by 1970. White flight left Detroit with a suppressed local tax base, under-resourced schools, disinvestment, and this is too common in metropolitan areas across the United States. This disinvestment, coupled by residential segregation, too often enforced by policy and practice, and maintained to this day by discrimination in the housing market, is something that we health professions need to confront and tackle, because it's at the root of our challenges related to the pipeline. If we can't harness the talent of our young students of color because they're attending under-resourced schools, then we all lose. And too often, frankly, we health professions are competing against each other for those students who are clearly talented and have the preparation. The problem is that we have not recognized the talent of our students of color and invested accordingly. So we've got to understand racism for what it is. I'm a fan of Dr. Kamara Jones's definition of racism. She says racism is a system which assigns value and allocates opportunity based on what you look like, your skin color, your hair texture. In doing so, it unfairly disadvantages many, many people who could be contributing to our society, and unfairly advantaging others, but therefore contributing to a waste of resources for our entire society. In my own writing and thinking, racism operates at 4 levels. I know there's some disagreement, but I want to make a bit of a distinction here. Racism operates clearly at interpersonal levels. We see that every day. We see that with evidence that the name on a resume can influence whether or not a job applicant can get a call back. I'm referring here, of course, to the research showing that African-American sounding names are less likely to get job interviews and subsequently hired. We also know that there's discrimination in housing markets. Audit studies show that paired testers, one white, one African-American, for example, given the same financial background, fictitious of course, the African-American pair tester is more likely to face discrimination, whether it's in regard to renting a property or receiving a mortgage. So segregation is maintained today, and that's a structural form of racism, in my view, because it helps to prop up systems of inequity and maintain racial inequality. Institutional forms of racism are policies and practices of school systems, law enforcement, healthcare systems that, while facially neutral with respect to race, nonetheless help contribute to disparate racial and ethnic outcomes. So we need to be constantly monitoring for differences in access and outcomes to see if racism is operating here. And finally, there's internalized forms of racism. You all may remember the famous psychologist, Dr. Kenneth Clark, who performed the famous doll study test in the 1930s and 40s. This research revealed the depths of internalized racism among African American kids. When white and black kids were shown a brown or a white doll in these tests, they were asked, which doll is the nice doll? Which doll do you want to play with? Which doll is the better doll? Invariably, all of those children pointed to the white doll. So this kind of research, sadly, can be replicated today with the same results. We as health professional organizations need to come together to be clear about how racism operates. I'm less concerned about individual acts of discrimination. Discrimination persists, but we've got to focus our attention at structural and institutional levels as well, and be thinking about how our behavior in those systems helps to prop up those forms of racism. I thank you so much for this opportunity to speak with you all and look forward to the discussion.